My name's John Beltrame. I'm a cardiologist working at the Queen Elizabeth Hospital and Royal Adelaide Hospital, and also the Director of Research at Callum. And I'm pleased with the topic that we're going to cover today, which is on PROMs. And I'll tell you a little bit more information about that in a moment. But just as an introduction, I just wanted to point out to everyone that the session's being recorded, and that also if you have any questions for our speakers, who I'll introduce shortly, and then please enter them on the Q&A section on the Zoom window. But before we start, what I'd like to do is to acknowledge the land, the land that we meet on today, the traditional landowners of the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge that the Kaurna people as custodians of the Greater Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. We have two speakers speaking on the topic of PROMs, which stands for patient-related outcome measures. PROMs are particularly important because they underline the importance of holistic patient management. Far too common in medicine, we focus on disease. So as a cardiologist, I'm interested in coronary heart disease. But there's also other aspects that we need to consider, because the patient doesn't present to us with coronary heart disease. They present with symptoms such as angina. Those symptoms result in functional limitations because they can't exercise, because they develop chest pain, and then that impairs their quality of life. So what we need to do is change the focus from disease-focused to patient-focused. And that's what patient-related outcomes, or PROMs, is all about. And so now we're going to hear from a couple of experts in the area. So the first of these is Megan. So Megan Scott, who has been a paediatric nurse for 25 years, but more recently has been involved with the implementation of the electronic medical records, and is currently working in the Commission on Excellence and Innovation in Health, particularly focusing on PROMs. So Megan, I'll hand it over to you.
Okay, hopefully you are seeing the presentation and hearing me as well, John?
Yes, well.
Perfect, excellent, I'll get started. Thank you for that introduction. So with regards to patient-reported outcome measures and patient-reported experience measures, which I'll collectively refer to as PRMs, patient-reported measures for short, I'm not quite sure of the audience's full knowledge of those. So again, I do want to apologise about any information that I'm giving you that you already know, but really being unsure, I wanted to give you absolutely everything that you might need. So obviously PROMs, or patient-reported outcome measures, are surveys about health outcomes for patients, and they're really I guess, estimates of quality of life, and that can be in relation to pain or mobility or functioning. PROMs can be generic, general questions about quality of life, or a little bit more condition-specific, related to a specific disease, illness, or procedure. PROMs can be collected before or after a healthcare intervention or a procedure, showing the impact of that procedure on somebody's life. We can also collect PROMs once or survey patients over time, and really help patients to utilise that information to inform their decision-making. PROMs obviously are a little bit different to outcomes. They very much focus on experience measures, and particularly, I guess, about patients' interaction with a health service, be that the physical environment that the service has provided, the behaviours of the staff involved in their care, or also aspects of the clinician and patient interaction. Those experience measures can be general or can actually be targeted towards different patient groups, and that may be children or Indigenous patients, or say, for example, renal patients. We're aware that there are some collection measures of experience going on in that area. Now, obviously, surveying patient experience can help us as healthcare providers to make immediate improvements to the patient experience, and also, therefore, improve the health outcome for the patient. So in terms of benefits of PRMs, obviously, as I've mentioned, patients who report better experiences will also have better health outcomes. Measuring a patient's outcome from their own perspective and their report particularly helps us as healthcare providers to tailor care to meet their needs. Obviously then that has a follow-on benefit to staff experience. If patients are having better outcomes, then the staff experience as a service provider will really I guess, impact positively on their health and well-being. And really one of the key drivers and benefits for PRMs is that move towards value-based healthcare, which is very much about measuring health outcomes, about the cost of delivery, against the cost of delivery with the aim of improving better care. We can also, when we're looking at our PROMs data that we are collecting, using it at an aggregate level, obviously de-identified in most instances, to really, I guess, collect data that will improve efficiencies and potentially change service models. And certainly we are seeing some examples of that within South Australia. So in terms of the statewide PRM program vision and goals, functionally, the way that we got to this vision and goals is we did actually hold a stakeholder workshop in June of last year, which I'll go into a little bit more detail as to where that sits within the program roadmap. But functionally, what you're seeing on the screen is the vision that was articulated to us by the workshop attendees. And very much that's a health system that recognises patient-reported outcomes and experiences as vital, where feedback is available in real time and does actually support consumer decision-making, and that the data that we get from that is actually used at health service and system level to drive excellent care. Now, our principles are really based around excellent user experience, and that's some of the very obvious stuff around a great user interface for our patients who are using any technical software that we're implementing, a system that's co-designed and provides information for the right people at the right time. We obviously have that overarching principle of safety as well, and that's both in terms of the traditional notion of healthcare safety, but also for some of our consumer groups, cultural safety is very important for them as well. Obviously, we have the elements of data privacy and security that also inform that safety principle for us. We really want this program to be clinician-led and consumer-focused, and by that we actually want to build it into existing workflows. We don't want the collection of PROMs and PREMs to be something extra that clinicians need to do as part of their interaction with the patient. We very much want the information that we do collect to inform patient care and really support that process cycle of continuous improvement and innovation in health. Our final principle is one that I've had personal experience with in the implementation of various change projects within health, and that's just get on and do it. Let's actually make a start about doing about this and really refine it as we go. And you'll see in my next slides when we talk about the program roadmap, how we're going to achieve that. So where are we? Where have we been? Where are we going? As I said, phase one for us occurred in June of last year, where we held our PROM and PREM workshop. And we had great attendance, nearly 100 attendees that comprised clinicians, consumers, obviously healthcare administrators. We had researchers, also academics, and crucially, we actually had our colleagues and counterparts who are delivering statewide PRM programs interstate and also internationally. And so that really, I guess, gave us the impetus to start with phase two, which was putting up a business case to the CEO of SA Health, designing our stakeholder engagement strategy and forming a technical reference group for the software component of our PRM program. Our business case was submitted earlier this year and was approved, and the program formally commenced on the 1st of July this year. We got approval to do a 3-year program. Obviously, in the first few months since we've been together as a team, we've very much been focused on establishing the governance arrangements for the program. Our program board is due to meet at the end of this month for the very first time, and at the same time we're about to go into an open procurement process for our technical solution, which is what patients will enter their survey data into. Our very first implementation is scheduled for the second quarter of this year, next year, loosely March or April. And my following slides will talk through how we're going to, I guess, approach that. We are planning, obviously, as you would normally do, an evaluation after our first implementation, and that'll move us then into phase 4, which will actually, which on this slide looks like it's just one phase, but it will actually be multiple implementations across various clinical services. Then obviously we'll look to embed the use of PRMs across clinical services statewide, and very much work to refine and add more outcome and experience measures as we move further along our implementation pathway. So in terms of our implementation approach, 3-year program, as I said, staged implementations. Our program board is actually going to decide who our very first in-scope services are, but certainly what we'll be recommending is the services within SA Health that are already collecting patient-reported outcome measures for us. There is quite a lot of work already done by SA Health in regards to PROMs or experience measures, and we're not seeking at this point in time to cease that collection of that data. So our initial focus will be on PROMs, and then later we'll move to actually develop some new experience measures. Another common question that comes up at this point is what measures will we be using, and will we be deciding those? And the answer is no. The clinical services that we work with, the clinicians themselves will decide which measures that they are going to use, but absolutely the intent is to use validated measures initially. And then as the program matures in terms of its application, we'd certainly like to see the development of new experience or outcome measures developed by clinical groups. This slide briefly goes into a little bit of technical detail as to how the collection of the PRM data will work. Rather than talk you through each dot point, functionally a patient will actually receive an invitation to participate in a survey, and that will be controlled by a local administrator of the PRM program, be it at a clinical service or hospital level. Now the slide says the survey may be emailed, but we're also actually looking at QR code enrolments, text message, or any other variety of technological advances. We're not going to tie ourselves to just one option. We are hoping to really, I guess, have that flexibility for patients. Obviously, patients will then complete their survey online on a web portal, and that is the piece of software that we're going out to procurement for at the moment. Obviously, we do know that some patients may not fill in their surveys before their appointment, so there will need to be a mop-up process, but functionally that collected survey data will be stored on the portal. The patient should be able to have access to that to see their completed information. The clinician treating the patient should be able to have access to that, as well as the local area administrator should have access to that aggregated data to then use that, not only for that quality improvement, but potential future research areas that they may be involved in. So the final point that I wanted to make was we advertised through the CIH social media channels recently our PRMs Research Collaborative, which we're looking at establishing. That's some work that we're doing in conjunction with Health Translation SA, and really the aims of that research collaborative are to optimise the translation of evidence from PRMs, really with that drive to enhance patient care, change health policy, improve clinical practice, and potentially realign some of the services and the way that they're actually structured in terms of delivery. We'd like to establish an influential PRMs research portfolio. At this point in time, none of the other states within Australia do have a research collaborative specifically in relation to PRMs, even though they are undertaking PRM related research. We very much do want to use the collaborative to embed that PRMs research within health services and departments. We very much want to build capacity and capability in the evaluation and monitoring of healthcare practice with regards to PRMs. So I just thought I'd end giving you a little bit of pointers as to where to seek more information with regards to us. You've got our 3 social media channels there. You also can email the team directly, and we've also stood up a PRMs website which has a number of resources that are available for both consumers and clinicians who are interested in undertaking the PRMs journey.
Thanks very much, Megan. That's a terrific program and very ambitious, and I think a very important one because this is the future of healthcare, I think, directing it that way. We've got a question for you online. So this is from Melanie, and Melanie asks, how do you perceive that PROMs can be built into workflows and inform care without impacting on workloads?
That is a fantastic question, and one that in my prior position I pretty much have done for the last 10 years. So really what we're aiming to do is to have the data filled in by the patient available to the clinician in real time during the consultation. Now, for those of you that are familiar with SA Health, obviously a number of health services have gone live with the Sunrise EMR, the electronic medical record. It is our vision that a completed survey will be available within the EMR. So say, for example, I'm sitting in a clinic room seeing a patient. I'm actually typing my clinic note, talking to the patient, and I can actually have the completed survey information available to me from within the EMR. So that's one element of the interface work that we're actually needing to achieve before we do go live. The other element is obviously for services that haven't gone live with the EMR, they will also need to have access to that, and they'll do that through a web link to the software vendor's portal, needing to obviously log in and then look for their patient group during the clinic. So that's how we're hoping to, I guess, minimise the disruption to workflow on that front.
Okay, thanks for that, Megan. You're very popular. We've got another question for you. So this is great to see. It's a very interesting area. So this is from Cleo, who asks, some older patients may struggle with the use of electronic devices. How have you taken this into consideration in the formatting of the survey?
That is a fantastic question. I'm so grateful that you asked that, because I didn't actually make mention to any of that. We're attacking that in a number of different ways. We are going to heavily involve consumers in the testing of our product, and we've actually had some very specific feedback from the services already using PROMs and PREMs that this is a key consideration that we need to, I guess, take into account. And so what the services who are currently already utilising PROMs and PREMs do is they do factor into their clinic workflows that a certain percentage of patients may not have been able to complete the survey electronically, and that's where the QR codes come in to use in terms of the patient fronting up to clinic and being assisted and supported. Perfect example of that is the hand team, the plastic surgery hand team at Sarlan, who actually obviously have got a patient group who may not have use of their hands temporarily due to injury or illness, and so they specifically need to develop clinic workflows to support that patient group to complete their PROMs data. The other thing that we're also doing is we have within the CEIH a user interface, a UX UI developer who has specific experience in the elements of user interface, and so we're really looking to leverage off his skills to optimise the design and appearance of surveys in the technological platform. Obviously, we need to also account for linguistically diverse communities as well, and there is obviously that potential to go down the path of translation of surveys as the program matures.
Okay, there's a couple more questions, but I might save one for later. So the final question for you is, how will the perception that honest feedback may lead to altered care, perhaps negative, be addressed?
That is a great question as well. Thank you for that. We do hear that quite commonly from clinicians, certainly a bit of nervousness, not only from patients and clinicians, but now that we have this information, what are we going to do with it? I had a very interesting conversation with a researcher from Holland last week, who said that overwhelmingly, and this was in the area of cancer PROMs, overwhelmingly the patients felt it impacted positively upon their experience, having access to not only their own completed data, but being able to compare that against other patients. So her feedback was that initially they thought that was going to be a problem and may inhibit patients from participating, but it turned out to not be the case. And they're actually, she said, due to publish in the next 3 months or so, their findings specifically in relation to the provision of of the PROMs information back to the patient and how that impacted upon the patient journey.
Okay, well, thanks very much, Megan. We might move on. So our second speaker is Associate Professor Rosanna Tavella, and Rosanna's the data manager for the CADOSA registry, or the coronary angiogram database of South Australia. And so Rosanna's very experienced in this area, having done a PhD, I think almost 10 years ago, focusing on registries and particularly health outcomes and particularly PROMs. So she certainly has a lot of experience and is well qualified to talk on this topic. So thanks, Rosanna.
So I'm going to just give a brief overview of the CADOSA registry and the work that we've done in South Australia in implementing PROM measures in our patients with cardiovascular disease. So briefly, CADOSA is a key quality improvement and research infrastructure for patients undergoing coronary angiography or stenting procedures in South Australian hospitals. So we have a statewide collection of all consecutive patients in the public sector, and we also have data capture in one of the major private hospitals as well. One of the key attributes of the CADOSA registry is the team, or the team of staff that we have that are have a primary role in data abstracting, so collecting the clinical data to inform the registry, but also having a role in administering PROMs to patients in hospital and during follow-up. And over time, these positions have really become a key component of the cath lab safety and quality program. We have a steering committee with representation from each of the participating hospitals that provides a oversight on the clinical and data governance framework for the program. So there were three key components to the program. Firstly is the clinical collection, which I've just mentioned, where our staff can undertake a baseline data capture. And then we work with our data linkage units to look at clinical outcomes over 12 months, including mortality and return hospital visits. Our patient-related health outcomes component includes a baseline capture of PROMs, and then in selected patients who consent to be followed up, we have a collection at 1 month and 12 months post-discharge. And lastly, we also have an integrated biobank where we have a blood sample drawn during the angiogram procedure, which is then processed down for long-term storage. Now, just a couple of other comments on CADOSA. One of the other key attributes is our linkages with our international partners. So in establishing the registry, we established our data collection based on best practice standards of cardiovascular data banks, and that was modelled from the National Cardiovascular Data Registry, which is run by the American College of Cardiology in the United States. And because of our compatibility with this program, we are recognised as an official international affiliate site of the NCDR, so that we're the only site in Australia and certainly one of few sites outside the US that has that compatibility. And likewise, with our PROMs collection, we have modelled our PROMs capture on what's been recommended by ICHOM. And ICHOM is the International Consortium for Health Outcomes Measurement. And this is a non-for-profit organisation that has been developed out of Harvard Business School and is promoting the need to collect PROMs as a way to drive value in your healthcare system. And they have developed a number of standard sets of data for different disease groups where they've identified the key clinical information, but also more importantly, the key PROMs that should be measured for different disease groups. So CADOSA is completely compatible with the ICHOM standard set. And these are the patient-reported outcome measures that we're currently capturing. So we have a number of, we have a range of both disease-specific and generic measures included. So we have the ROSE questionnaires, which look at angina and shortness of breath in our coronary heart disease population. We also have the Seattle Angina Questionnaire, which is a key coronary artery disease measure that looks at the impact that the disease, in particular the angina symptoms, have on a range of domains in the patient's life. We also have a generic measure, that being the EQ5D. And then we have another disease-specific measure looking at depression in our cardiovascular patients. So as I mentioned, we are compatible with the ICHOM standard set. And again, we're one of few international sites that are meeting these recommendations. So one of few internationally that have implemented the full set for coronary artery disease. So we have the full ICHOM set, but some additional elements on top of what ICHOM recommend. So for example, with depression, there is a recommendation to collect the 2-item PHQ, Patient Health Questionnaire, but we have gone with the full PHQ-9 version. And we also have an additional general PROM being the EQ5D, and this gives us the ability to undertake cost effectiveness analyses. Now, when we are implementing these measures, particularly disease-specific measures, we need to consider the potential to gain new clinical information about the patient's status. And as an example, the PHQ-9 questionnaire has a direct question about a patient's potential suicidal ideation. So in implementing this collection across the hospitals, we worked with each of our cardiology departments to formulate an appropriate notification process and follow-up pathway for patients for where this information was identified. So if this occurs in hospital during the baseline visit, the CADOSA staff would notify the medical officer, and then there would be further discussion on what further review would be appropriate for the patient. However, if this occurs during a PROMs follow-up, which are undertaken via phone, the CADOSA staff would, with the patient's permission, would notify their GP and provide the GP with some further information and recommendations for further assessment. And over the phone, the CADOSA staff will provide information to patients such as Lifeline and Beyond Blue contacts. So over the years, we've actually been quite surprised at the number of referrals that have come through the depression questionnaire. So we've had close to 90 patients that have received further follow-up from this process. And some of them have had no history of depression or no treatment of depression. So this questionnaire, this process has certainly enabled them to get additional support and help that potentially they may have gone unrecognised. So how do we collect all of this data in practice? So we have a huge amount of data that we're collecting, and so we have a few different models of collection. So our clinical data is quite extensive. It includes a 16-page case report form, and so this is largely a hard copy collection with entry into a web-based platform, but we're looking at ways where we can reduce that paper-based collection with the use of tablets. Our PROMs collection, our preference is that our initial contact with the patient is a face-to-face interview during their hospitalisation. But of course, during COVID, we've had to make a number of amendments to continue to enable the collection of PROMs. So we now have processes that enable for remote consent, and also a baseline collection conducted via phone following an invitation letter. All of our follow-ups post-discharge are largely completed via a phone interview, but we've also done some work piloting a web-based and electronic collection of PROMs. So these are the couple of the e-collection methods that we've looked at. Firstly, through SA Health, the patient feedback portal, which is where the patient experience survey is captured. We were able to modify this portal to include our disease-specific measures, so our angina and shortness of breath survey, and we trialled the use of iPads in hospital, where our staff provided to the patients and asked the patients to complete the survey before they were discharged. We've also trialled a commercial product called Join My Care, and this is a product that's been designed to really engage the patient in monitoring their own responses and looking at how their symptoms and quality of life track over time. So in this product here, we trialled a process where all surveys were completed online by the patient, including in particular the 1 and the 12-month, and patients would receive prompts via email to log onto the system and complete their surveys at those trigger times. Just to summarise the work that we've undertaken, so we've been administering health status questionnaires for over 10 years in CADOSA, and prior to that I'd done quite a bit of work in my postgraduate studies learning how to optimise the collection methods to keep the patients engaged and have optimal follow-up over time. And our original process, which was really a traditional mail-out approach, did not work very well. So during my postgraduate studies, the follow-up that we would get from mail-out was around 70%, and over time we've now replaced this with a phone interview approach, and we've seen really good completion and engagement with patients with this approach. We've seen that the e-collection methods may not be suitable for all patients, and so I certainly think a hybrid approach is the way to go to have optimal engagement and participation by patients. One of the key achievements that we've had in the last couple of years is now administering a baseline PROM for all of our CADOSA registry enrolments. And this comes from the recommendation from the American College of Cardiology, where all the cardiac patients should have at least one disease-specific assessment during their care process. And what we're doing is assessing the angina and the shortness of breath questionnaire as patients are coming in to have their angiogram. Now, for patients who participate in the full ICHOM set or the full standard set of questionnaires, so these are patients that consent to be contacted and followed up over 12 months, we see really high rates of completion with our methods, which is largely, as I've mentioned, undertaken via phone. So we have almost 2,000 patients that have enrolled in our follow-up program, and we are very pleased to see that we maintain around 90% engagement and completion of surveys from patients once they've been discharged from hospital. So to conclude up the presentation, I'll just leave you with this slide here from ICHOM, which is one of the benefits that Megan alluded to at the start of her talk, in that the value in your healthcare system is really driven by the numerator in this equation. So that is whether we're achieving the patient desired health outcomes, and that if you're striving to improve those, your costs should improve, thereby increasing the value in your healthcare system. But a lot of the work has to start from finding ways where we can implement routine assessment of PROMs, or measuring the outcomes that matter most to the patient. So I'll conclude there and just like to briefly acknowledge the investigators, the clinical investigators on the program, the staff, and also our funding partners and international collaborators. So thank you very much for your time.
Thanks very much, Rosanna. So I might, because there was a question from Megan's presentation that's probably relevant to this one, but I might address this to Megan. And so this was Paul Bennett asked, are or will you be discussing with research teams who are currently undertaking PROMs research, e.g. Swift dialysis PROM study? So I guess you mentioned, Megan, about sort of the researchers. There's a couple of examples that are already collecting PROMs and how you'll integrate with those.
Absolutely. Thank you very much for the question. The answer is yes, we have engaged specifically with Stephen and Laverne running the Swift study. So we're very aware and really, I guess, hoping to translate some of the learnings that they've been able to share with us. We've also met we're essentially at this point in time wanting to meet with anybody who is involved in the area so that we can not only talk through what we're doing, but also apply any learnings that they may wish to share with us. Certainly the Silent Oncology team, who've just recently finished a PROMs project, have been very forthcoming, as well as both the plastic surgery teams as well. So absolutely, if there's anybody on the call who would like to make contact to talk further, I'm more than happy to set that up.
I'd like to thank our two speakers. I think it's a very interesting area and good to see the responses with questions. Thank you for everyone for tuning in. And just to remind people that next week it will be the University of Adelaide Public Health. So thank you very much and good evening.